Our healthcare system is broken. So let's do something about it. We've launched the Real Value Exchange, a podcast to share the stories of providers, entrepreneurs, and the change agents pushing healthcare forward.
So on the way to go interview Dr. Lee. He's the head and leading this MII, which is the Medical Innovation Incubator here in Los Angeles County. So I'm excited to have this conversation because I think he has some different strategies that he's deploying to really help change up how we view healthcare and how we operate, especially with diabetic care, which means a lot to me. So with that said, guys, I'll keep you posted on how this shakes out. Now I'm just trying to find the building where it's located in. Dr. Lee, how you doing? I'm Joe Lemon. Yeah. Great to meet you, man. No, you're good. And I got to tell you, Dr. Andy Lee, he's up to some serious things. So what his incubator is about is bringing in patients as well as physicians to try to solve issues around how fragmented the whole healthcare system is. Now, this is really important because I haven't seen anybody else do this throughout the U.S., but they're asking the patients what they need. Now, this sounds pretty simple. It sounds like elementary business practices. Like if you were launching a business, you would want to talk to your customers. You want to listen to them first. You want to understand what their true needs are, what their real desires are, especially in sales. You understand that sometimes, most of the time it really comes down to a price play, like who has the cheapest price, but maybe somebody wants to save time because they want to spend more time with their family. Whatever that problem that you're trying to solve is, digging into it and understanding what the real roots of their pain really are, and then coming up with a simple solution is something I've never heard of people doing in healthcare, and that's what he's setting out to actually achieve with his MII group out of LA. Well, you know what? So let's kind of start back at the beginning. I mean, and I definitely want the audience to kind of have a better feel of what you're up to. Do you mind just telling people how you got into this actual position a little bit? So maybe kind of talk about why you even chose to become a doctor in the first place. I would love to hear that.
Yeah, so thanks for having me on the show. I love the fact that you're having these conversations. Specifically for me, I was born in Taiwan. I came here when I was 6. Wow. And I was raised by my mother, and I have a younger sister. So, it's a standard immigrant story. My mom kind of barely spoke English and figured her way out. Went to college and basically worked in banking. For me, I ended up going to college in Berkeley, went into medicine, and now I'm an endocrinologist. I think for me, I think it was always kind of expected to go into medicine in some way, but it wasn't. I think I have a different relationship with my mother probably back when I was 3. My father actually died of a stomach cancer. So, and thereafter when we came here, we were pretty much left on our own. I would say I was Generation X. I was a latchkey kid. My mom kind of had she was trying to put food on the table, get her education and basically, figure something out for us. And we kind of just did our thing. But I've always felt like I love medicine. I love the medical field. When I did go to college, I really loved the humanities. I love social science. But at the end, I don't think I would have pictured anything else. My view was always, trying to help others, and what better field than to be a physician. So, but yeah, that's kind of just my quick background. Where I'm here at LAC+USC is with the change in the healthcare system and the need to roll out the ACA. They really needed to expand the outpatient specialty practice. So I'd been an endocrinologist manning clinics, and they saw an opportunity for me to come as a leader to help lead the outpatient clinical experience. So I've been in my role as a outpatient specialty director since 2013, And with my issues with how county healthcare system was run, I designed a medical innovation incubator, and that's where I'm right now.
So this is something that you have led up by yourself for the most part, where you kind of took that actual lead to say, I think we should have this incubator instead of county hospital?
No, so yeah, that's you never do any of these things on your own.
Sure.
And, I think the shows
that's a good point.
Probably I probably take too long to thank everybody that helped me through this project. But I would say that with anything that I've done, it's really out of necessity. I didn't set out to do a medical innovation incubator. It was because I had, in my mind, insurmountable obstacles that I had to overcome. Roughly around 2016, I was part of this California Healthcare Foundation Fellowship. It was a leadership fellowship that was up in San Francisco. And part of that project was really to design an intervention to help healthcare. And, as an endocrinologist, I wanted to help diabetes, and I felt I had a model, but I had a lot of problems implementing in the county. So as I looked at other major corporations like Google and Amazon, I realized they had to have an innovation incubator to test out new ideas. And I took that model and I came back to the county and I said, we should have one here at the county so that I can bring more folks with me to really change this rigid system of the county. And we've been running ever since.
That makes sense, though. I mean, because, you definitely hear lots of companies like the Googles and the Amazons have these own separate incubators where they test out different projects. I think it's a great way for people to kind of come into it and have these ideas and see if these ideas are really valid, right? Because especially in healthcare, lots of the problems are so complex with lack of transparency and just a lot of these models that people want. But you guys have a pretty cool opportunity because you obviously cover LA County, and it's a huge county, and you get to see a little bit of everybody and like everything, right? Mm-hmm. so all right. Let's kind of dive into what some of the issues that you guys try to tackle here.
Well, that's a big question. Let's start with such a big question, Joe.
Yeah.
So just as in context, LAC+USC Medical Center, we're the biggest medical center in the county, but we're a government-run healthcare system. So healthcare is already very complex, and then adding a layer of government-run that makes it almost impossible sometimes to change things. So we have unions. We are also a training institution, so we train residents and fellows. We got very complex patients. So, I think we have major problems. But I think that probably the biggest problem that I saw when I was here was trying to figure out, who are going to be the leaders that's going to lead us through this whole turmoil of healthcare, right? And I was just surprised in the development of this incubator of where leadership can come from. Because I think in the old days, I think there was kind of maybe a clear executive leader saying one clear direction.
Right.
But I have to say that what's really changed and transformed over these last few years from Dr. Katz now to Dr. Galley is that they're really bringing in an inclusive group of people to give us really bright ideas. Right, and what it does is it brings together communities where we're tackling problem not just from one direction but multiple different ways, such as if you're looking at obesity or diabetes, we're not just looking at coming to clinic. We're looking at how scheduling appointments are scheduled. We're looking at upstream things such as in wellness. How can we prevent obesity? And we're talking about mental health, how we can actually address some of those psychological barriers in becoming healthy. So I think that the leadership has changed in the way we look at problems. And because of that, it's brought greater academics, greater interest in a lot of people to solve the problem in different ways. And because of that, I think we become much more successful in not just treating the problem, but come up with different ways to save costs and deliver better health care. But in answering your question, what is the biggest problem that we have?
That is a loaded question, man.
Yeah. I think we've been very successful over the years to make ACA work,
mm-hmm.
I think if the election would have been different, I think the leadership team probably would have been in Washington, to be honest, showing how we succeeded. So we show that within a county, when we were responsible for the dollars to provide healthcare, we were actually very effective.
Wow.
We saved costs. We made health less expensive. But I think the biggest challenge moving forward is really getting together and to define what should healthcare look like next. Okay, and with the whole change in finance and things, how can we continue this momentum? And I think that's probably our biggest challenge. I know it's kind of very abstract.
That's exactly what I was looking for, actually, because a lot of times things come down to, people have a lot of great ideas, but when it comes down to how do you fund these ideas, right? Yeah. That's the biggest hurdle that a lot of people don't have a lot of answers for. And so trying to get the right people in place, as you were mentioning, I think is major. And finding those people, I'm sure, is takes some vetting and a little bit of time to kind of find the right people for those leadership roles.
What we did in this one venue, the Health Innovation Marketplace, is to bring these patients in their disease state together with the docs, the nurses, the social work, the pharmacists, and collectively have each one of the pods look at what they value the most out of healthcare and to come out with a system that delivers something that everybody likes, right? And this is, and I think we're going to need more of that in the future in trying to bring people together to develop kind of a shared value system and what we want healthcare to be so that we know exactly where our true north is and we put more of our resource in delivering those type of values.
Yeah,
So-
I mean, and you know what was kind of cool is that we went down this rabbit hole of talking about blockchain prior to me pressing record, but I think it was it was a very interesting conversation because people don't know how to really apply that technology to a lot of different spaces, effectively, and doing it to what's going to be best for the right there for the patient. I think is really interesting how you guys loop in the patient to help build up the actual service or these models that you're looking to kind of create. Can you kind of dive into that process a little bit more?
So simply put, one of the things that's very interesting for me as a leader, so I'm the specialty care director for the outpatient clinics. What I've been really interested in is something very simple, is how do you take a seed of an idea and make it happen? Mm-hmm. It's just simple as that, right? And it appears that in healthcare, it is tremendously difficult because sometimes people are not allowed to take an idea and to even show a proof of concept, right? That's one problem. So I think there's a failure of just inclusiveness. Not everyone's part of the strategic design of how healthcare should be delivered. So that's one. Number two is that when you do have an idea and it's working, not everyone recognizes it because it may not be part of the master plan. And we don't value new innovations. In a big system, we tend to kind of want the old, the proven, the status quo. So really to change the traditions or some of the routines, it takes quite a bit of force, right? Yeah. And so what I really wanted to really investigate was how do you get an idea quickly prototype and tested? And when you test it, how do we rally people around scaling an idea? And I at least within a county, I didn't feel like there was anything like this. And I would say for most businesses, this is a problem, right? They call this, when you create something new, you might cannibalize your existing process or your business. Yep. And nothing worse than coming as an employee, knowing what to do, and next day someone says, we're changing the whole system, right? Yeah. So these are growing pains for small businesses, but for big businesses, this is I think in business they call it the 3-box challenge. Mm-hmm. There's businesses, part of your process that you have to eradicate. There's part of the ones you're trying to be very lean, and there's new ones that's going to make your other 2 boxes irrelevant, right? So I wanted to see, I think in healthcare, what is the best system to create an innovative idea and being able to convince others that, to give you the opportunity to test it. And then if you've shown that it's effective, how do you get that scaled? So the incubator was kind of like the first step in trying to get a blessed space, okay, where you allow people to come together and just to convene and to have mutual respect over the principle that, you know what, everyone has some value in the way they look at things. And we want to take their idea and give them an opportunity to test it in an environment where they'll be supported. I have to say that it started off being very rocky. It got better.
Sure.
But it became, I quickly realized that, and this is from the support of the California Healthcare Foundation, they gave a lot of leadership tips, and I had a very good network to help me. But I realized it was more about the space. It's just the mental approach to facilitate and get people to the point where they're able to share ideas and try it is the biggest challenge. Okay, it's people are in a business of either status quo or actually trying to push together an idea where they feel things are right. But getting together a team that's willing to share and be more kind of blue ocean, being able to think outside the box, but yet come together and be pivoted by other members of the team. Mm-hmm. This is a tremendous challenge. But the people who do, they come up with extraordinary things.
How did you get people to kind of move in that direction? I mean, because I could see that being a huge issue. You're working at the county hospital, or people, I'm sure people have been there, 5, 10 years, 15 years, not 20 plus, right? And they've been moving in this direction for all that time. And then all of a sudden you come in with the incubator and say, all right, guys, I want us to all open up.
Yeah.
Right? Right.
Yeah. So, I mean, these are huge topics.
Yeah.
But I would say that when I came in with the incubator concept, I think I created probably more enemies than supporters.
Sure.
Because if you kind of understand the innovation adoption curve, or just the just in terms of how ideas are adopted,
mm-hmm.
most visionaries are probably going to be at most 15%, right?
Yep.
So, and you have
to try to cross that chasm, right?
To cross that chasm, the majority is going to be in that 35% major adopters, and you got late adopters who are going to convert to the major adopters, right?
Mm-hmm.
And there's of course laggers. So laggers are clearly the ones you're always going to see. So if you park yourself with the creation of an incubator, you're going to be in that 15%, right? So you've automatically created enemies. So the biggest challenge,
it's true,
right? Because essentially your existence means a lot of people are not doing their job.
Yeah, yeah. And you're challenging everything that they kind of.
Absolutely, absolutely. So one was the design issue of an incubator. Okay, because if you're going to come through and tell people that they're going to do their job better, then I think it creates an environment where people feel they're either being evaluated, or they feel maybe their 20 years of service is meaningless because you're coming in with a new guard and you're going to change things.
Yeah.
So the first phase of incubators we delivered, but I don't think we were successful. All right, meaning that the success wasn't embraced by the collective.
Sure.
Right.
This was. How many years ago?
This was 2016.
Okay.
It was 2016. So we had some initial projects, and I think it went very well. But success can bring a lot of bad things, right?
Sure.
You can show that you deliver with less resources, and then it creates some. In my mind, I feel it's a success, but I think what I didn't realize was, it just never ends, right? You're always going to be delivering better performance. But what healthcare really needed is we needed people to emerge as leaders, right? And what leaders did we want to bring in? And I personally had to reevaluate my leadership approach.
Wow.
Because I would say early on, I didn't understand the value of people who worked in different sectors of the healthcare system, whether it be administrators, nurses, or pharmacists, or other things. I mean, I had my view, but the point is, you have to create some avenue where you're allowing them to emerge with their own perspective, and you want them to drive maybe you want them to get to an outcome, but most likely not the way you want it. So not so process driven, but more outcome driven. And that's very difficult for a lot of, type A people who are outcome driven. You feel like you have one way of doing things.
It's worked in the past for you, so therefore you kind of want to just try to stay on that path.
It's
as a leader for the most part.
And again, it's really, what's the point of the incubator, right?
Right.
Is the point of the incubator that we try to deliver really great products? And I would say at this moment, it became more than just a space. It's more of the concept, right? Like, what context we want to put people who have a seed of an idea, and I realized that small piece is very, very difficult. Okay, because people they can't understand it. So and I wanted to figure out a way to get the understanding that you're in the county, but you can think outside the box. But then you need to do it in a collective way where you're synergized by the people that work with you. So that first step is probably my biggest obstacle.
How long did that process take for you to kind of get people to understand that this is what the incubator is about?
It's still going. It's still going.
Ever evolving. Okay.
It's still going.
Yeah.
It's still going. So Joe.
Yeah.
I think every single stage I started to peel off things that was unnecessary.
Sure.
And I'm going to go back to the conference that I had, the Health Innovation Marketplace. Was that I realized the basic thing was we have to capture the value of the patient. And I needed the patient for the conference, each pod had a patient. So one of the critical pieces that we have within Incubator was I needed the patient to articulate the value the care team was trying to create. So that centered the team.
Gotcha.
And a lot of times,
so you have the patients almost trying to drive this conversation.
Yes. So the patient
awesome.
needs to be able to understand what you're trying to create. Mm-hmm. So then it's not a doctor view or nurse view; it's the user, right? Which is ultimately the patient. And I think it was just like in the conference. One of the remarks by the patient was, one of the patients actually kind of cried. She's like, I didn't realize all these people were working behind the scenes.
Wow.
Right, because she just remembered going to the visit, but she didn't realize people were scheduling around them. The pharmacist was reviewing all the medications. So, but it was a very interesting sight in this pod in the conference was that people were talking, but the patient was there, but they were talking as if the patient just couldn't understand the system, right? So we went around and we said, we're giving you a session, but the point is we want the patient to describe what you guys came up with.
Interesting.
And that changed the whole conversation. And I think this is where I think one of the biggest breakthrough for us was that we can groom patients that can understand the system just as well as some of the nurses or physicians. And they get to reflect back, is this something that is the outcome what you anticipated, and I think it then creates a different sense of purpose, and there's truly the outcome that's centered around like how the healthcare system should be.
No. I would say that's something that you see a lot in like startup culture. Right, mm-hmm. Especially with you being from the Bay and everything, right? Or you at least spend some time out that way. And when we talk about those startups, the one thing that they try to do is amass this list or this passionate group of people mm-hmm. that are into their service, into their products, and then they want to glean from them, exactly what they want. Mm. And those seem to be able to flip out to be some of the best services that people automatically buy into because they're pretty much telling these people, build this for me, right?
Yeah.
And so doing that in like healthcare, one of the biggest things that I talk to people about healthcare about is it's always so scary for everyone. Mm-hmm. It's complex. They don't understand it. So they take their hands off and say, somebody's got to fix it, right?
Mm-hmm.
Yeah.
Yeah.
And they almost kind of pass the buck.
Yeah.
But really, it's kind of all of our issue, right? We all have to figure out how to have some type of ownership in it. Mm-hmm. So I think what you're doing is pretty interesting, man. I was reading about how everything was so fragmented when it comes to like diabetes care, and then you had some ideas around that, right?
Yes. So in the past, the county used to be the way you manage diabetes is you probably, some people would bypass a primary care physician and go see a specialist.
Yep.
So how the county's changed is that we ask all patients to see their primary care physician, and we train the primary care physician to do really good diabetes care.
Okay.
And when they can't, they send an e-referral with us, and then we take the patients into the specialty clinic. So there's some there. You have a home base, and I think one of the biggest things in healthcare now is you need to have a primary care doc that will advocate for you at any point. Okay, because the specialist is great for a particular condition, but you need an advocate for all of everything you need.
Right.
So having a primary care physician is important. So when they see a specialist, specialists that I like to see actually in this healthcare system is that they understand their role in relationship to the primary care physician. They should always communicate to the primary care physician. They should always, explain to the patient how this is all one part of a big system, and you should always, go to your primary care physician on a routine basis and see the specialist as needed. But how we've changed diabetes care here is that we have a new complex care diabetes clinic, and the vision is that when people come, we have a collection of other disciplines. So we have a dietitian, we have a pharmacist, we have also besides the endocrinologist, we also have a nurse educator. So we're trying to put a lot of things under one roof. But our intention in creating this new clinic is that we want to deliver a very focused attention on diabetes care in 3 visits.
Wow.
And we want to be able to change the trajectory of your diabetes course and reintegrate their care back into the primary care physician. So we get a faster throughput. So this requires actually a very sophisticated team.
Yeah.
Okay.
Yeah.
Because we're saying that we're not going to do it over a course of 6 months. We're going to do it over a course of 3 visits. Okay. Because we don't want to waste the patient's time. Because for a lot of our patients, they work 2 jobs and things. They don't have the luxury of coming to multiple visits.
Right.
So our first phase generally for every patient is we do a very detailed assessment of where they are. Where's their dietary status? Are they not compliant with their medication? So we have a game plan.
Yeah.
So we go through and we recognize it's hard to change a patient's behavior, if we're looking at 10 or 15 things. So we decide to pick probably 2 or 3 big things that's really going to change the course of some person's diabetic course to help with a primary care physician, right? And then when they come in, we do a very focused dietary, focused medical intervention, a focused discussion about pharmaceutical adherence. And then we want to see if there's any effect by the second visit. And then we integrate them back into their local primary care doc, and we want to see that continued. So this is our intention to be more precise in the way we deliver care, so more precision medicine. And it really makes a specialist be at least more acquainted with the best level of behavioral mechanics, and probably use the best medication to change somebody's course.
Really cool. And so how's the overall type of outcomes been now that you've kind of trying to have it down into like 3 visits and then back to your primary care? How's that worked out? So I think the great thing about this team is we're realistic about the success and failures. Sure.
So
that's good.
So, and why 3 visits? We chose. Yeah. We felt 2 is too short and 3 is just about right. So that's the type of science it is. And
nice round number.
And we I could tell you that probably some of the initial failures were when we tried to transition back to primary care. It was tough. So our nurse came up with a really cool idea to do kind of a graduation group visit where they go through and we make sure that they know exactly what to ask for when they go into primary care. Okay, so and a few other things such as in the beginning we started some new medications, but when they went back to some primary care physicians, it wasn't on their formulary. So then we took on the position that we're not going to start any medications that the primary care docs didn't have at their disposal. So we learned from some of the mistakes that we've had before, And one of the things that we're potentially budding off is that we have a very good nutritionist, and we're thinking of actually doing from the success of getting patient under control with less medications, we might start probably the first diabetes remission clinic.
Wow.
So, and the goal of that is even higher than this, is to take someone who's on medication, especially on insulin, completely off with a very intense lifestyle regimen. So
can you go into it like a little bit? I mean, I'm just curious.
So
now,
just
if you can't, Doc, it's fine.
Yeah. So
it's totally fine.
So this is actually, there was an article written about on LA Times when I did this like very early on.
Okay.
So people were under the belief that once you have diabetes, you're just on this course of being on more and more insulin, right? And your beta cell failed. That's the cells within the pancreas, and there was this kind of just this pharmaceutical model that your disease gets progressively worse, and you're just going to need more medications. So I luckily was studying remission of diabetes post-bariatric surgery, and I was seeing people who had very aggressive diabetes, and after bariatric surgery immediately remit. So they're off medication. It doesn't take 2 or 3 months. Like the moment they have the surgery, they walk out of the hospital, they're off all of the insulin. It could be 200, 300, right? And this is probably for another day.
Okay.
So
Yeah,
it turns out it turns out when you do this bariatric surgery, there's something that magically happens with your hormones inside your gut that remits the disease. So you can lose no weight and you walk out and your diabetes is still like under control. So it's an incredible phenomenon.
Yeah,
so people have been studying this. Again, another subject on that.
I'll let it sit for this
day.
time.
But what I found, why this was such an interesting story was I was a trained endocrinologist that knew all the field, but we just had this construct that was very focused on putting on more and more meds, right? Either more combination or more insulin. And I was at a really good colleague that really firmly believed that lifestyle can have a huge impact, right? Just for me to even want to explore it. And luckily, we were very abreast with literature in Netherlands, and they did very aggressive, very low-calorie diets. And it goes through this, you need to be medically supervised.
Sure.
So we figured out a way to do this on a regular basis, and I was doing this with different patients. So I ended up having a whole series of patients that were on either 200 or 300 units of insulin, completely off, just with a very intense diet. So
that's phenomenal.
And we followed them. And again, it's not, some people do, but they ended up with less medication, but there is a role in diet even in very aggressive disease. Yeah. And for these individuals, they actually maintained their control for at that time, over a year and 2 years, and they were doing fairly well.
Wow.
So I firmly believe that there's opportunity to take people who are probably a little maybe early on a lot of insulin and to put them into remission per se, meaning that they're very cognizant of their diet. They're still diabetic.
Yep.
But they're controlling with an aggressive lifestyle therapy. And why, for a lot of people, they say, why do this? Right? Because they say, you can take, we have all these really great insulins, and my experience with certain patients is, it's not for all, but there are patients who really want these, right? It's part of who they are. Yeah. They feel that when they're on meds, as much as we want to convince them, there's some value when they feel they have complete control over their body, right? Mm-hmm. And they can do it with diet. Maybe it's easier for us just to administer medication, but there is value for them. Mm-hmm. And I'm going to say that it's not an easy course, but for ones that's been able to go into remission, they feel like they have a firm control over their path in their life. And we're thinking to do it again to show you that this is something that the county can do.
Wow.
So these are things that we're looking forward to seeing these coming months, and I know we have some really great projects, hopefully to share with you later on.
Man, you are pushing the pace for sure. If you're turning around projects in less than a month, I mean that's phenomenal. I mean seriously, yeah. I mean that's really pushing hard, man. Well, you know what? I definitely do appreciate this actual time. I appreciate the space. I think it's so needed for healthcare. It's a place where you're putting the patients at the actual center of it. Dr. Andy Lee, please tell everybody how to find you if they have any questions or if they want to learn any more about this actual fellowship.
Yeah, so I have a Twitter handle. It's at DRANDYLEE. So you can just find me on the Twitter handle. I was cohort 15 in this California Health Care Foundation leadership. On my Twitter handle, you can actually you can see the link to the fellowship if people are interested. But we're hoping to actually advertise more of what comes out of the incubator to show that government healthcare can change, and it can change because we have great leaders that's willing to push the envelope and think outside the box. So we're hoping to build more resource around that. Hopefully, more to come.
Love it, man. Love it. Yeah. Thanks so much for being on the podcast.